we have to continue with our ethical debate, and Jane will start to do or not to do. Yeah? Is this okay for you? And you come.
Yeah, this is great. So both of us had a hard time thinking to do or not to do, because I think we're beyond that. I think the question nowadays is more for whom and how. So we kind of titled this actually The Power and Caveats of Genetic Testing. So let's go through cases, and we want you guys to participate. You're going to be dancing later tonight, so hopefully you can stand up and participate and give us some of your thoughts about these cases. So this is a 72-year-old male who was seen by one of my colleagues who was diagnosed with MDS with excess blasts. He had an IPSS-R high risk with a normal karyotype, and he had no molecular done at the outside hospital. He had been given azacitidine, and after 2 cycles got hematologic improvement. But 4 cycles, he was now evolving to AML, and he was referred to our center for a transplant consultation. So my transplanter was very diligent and took this family history. There was nothing of concern here. He had 3 sons who were willing and eligible and excited about being haploidentical donors. The son who has the red star was very enthusiastic and was going to be the donor if all else went well. He then had MDS panel testing done at the University of Chicago, and this showed a DDX41 truncating mutation with a variant allele frequency of 50%. And at the time, this was from his bone marrow, which had 10 to 20% blasts. So what should you do now? Just wish that DDX41 was never on that panel in the first place. Call your favorite local germline expert, STAT, and figure out what to do and have them take care of it. Test the germline of the patient, all of the sons, both at the same time. Ignore it and proceed with whichever son is the best haplo option, which would have been that older son. So just to remind you, DDX41 mutations have now been identified in 1% of MDS and AML. And so some of these are germline and some of these are acquired. And we can use the variant allele fraction. If they're greater than 40%, they're likely to be germline. But this study, using TCGA data, shows that even lower allelic fraction variants can be germline. We also looked at this in our cohort of patients and found that the 13% of the variants were germline if the variant allele frequency was under 40%. And this seemed to vary by gene. So though these are small numbers, the truncating DDX41s were almost always germline versus something like P53, where only 7% are germline. So we also knew in the back of our head that there are cases of donor-derived leukemias if you use an unknowing mutation carrier in the family, like this one here. And so what my colleague did was call me, and we did testing of all of the above. And what we found was that that older son, as well as another son, both carried this germline mutation. And we ended up using the middle son, who was wild type. And so we have some questions and comments to debate about that we're hoping you'll participate in. Should DDX41 and these other germline genes be added to MDS panels? Because in truth, right now, they have no prognostic or therapeutic implications. And would tumor and germline actually be more efficient? So we talked about before that 20% of these panels will have pathogenic mutations. So should we think about doing tumor and germline up front, and how would we handle that? So I don't know if anyone is brave enough to get up and give their thoughts. All right, Ava, excellent.
Okay.
So interesting case. We actually just had a case where we have transferred a young girl. She was in her 50s, transplanted with her brother, and now both have evidence of DDX41 MDS. She got it back in 10 years. So we haven't tested whether it's donor but I think it's donor. So I think it's important. And I think since the data, the results of sort of registered donors are being so good nowadays, I think that if you have a DDX41 positive donor, you should definitely go for the registered donor. So I think yes on the first. The second question from what we do, but it may not be perfect, is that It's a bit of a cumbersome thing to grow fibroblasts and make a fibroblast germline, but we use T cells a lot. I know it's not perfect, but very often it actually helps you, and it's very easy. So this is what we would do, I think.
And you do them both at the same time? Like in the
if
same...
we have any suspicion, yes. But I mean, what we also can do is that we send myeloid cells and T cells, and then we discuss after the first results whether it seems to be reasonable to do another testing of the T cells. But you can send them at the same time.
Because in this case, we absolutely, if it had not been on that OncoPlus panel, we would never have known, and we would have absolutely used the sibling or the son with the mutation as a donor.
Yeah.
That was the plan, and the plan got diverted because of the mutation presence.
No, I do agree. I think this is nothing that you would like to give to a patient, definitely.
Yeah. And some people also ask about the ethics. Is there a coercion? Did those sons say, well, I'm only eligible to be a donor if you do genetic testing for me, and maybe I don't want to know that I have a risk of leukemia? I don't know if anyone has thoughts or comments on that aspect. Someone else has a comment? Yeah.
We need the mic.
In my institution, I work in the same institution as Jean Soulier, so we, in the gene testing, we incorporate all the frequent germline mutations and genes, and so we can detect GATA2, DDX41, and RUNX1, and certainly we would not, if the patient can be transplanted, we would certainly screen the donor. And we are supposed, at least in France, to have genetic counseling to test the family members, except in the case where there's an emergency, like finding a donor. And in DDX41 is especially interesting because when it's acquired, some results suggest that it could rather be associated with a favorable prognosis, although it has to be confirmed. So it's in the panel for both reasons, either as acquired or germline. But we do it. We're not supposed normally to test that as germline, but it's in the panel. I mean, it could be, and so it's very important prior to transplant. But I would, of course, not transplant a patient with a donor who has germline mutation.
I would just add that as a source of fibroblasts, this was taught to me by Heidi Marie Nitzel, who does a lot of Fanconi anemia testing. You can actually grow very quickly fibroblasts from the bone marrow aspirate. They just stick to the plastic and grow very fast. It's much faster than skin, so that's something that we've been using.
Yep, we've done that at our institution too. All right, so Akiko will present this case.
Okay, I just want to ask the chairman of the next session, who is sitting in the first row, do you agree that we continue, or would you like that we skip it at this point? No.
Then we'll continue.
Yeah, then we continue. Okay.
Sure, okay. So we'll go quickly then. So this is a 19-year-old college football player. He's a college athlete who presented to the University of Washington with chronic neutropenia. He's been told that he's had autoimmune neutropenia since age 10, no medications, negative family history. His exam is fine. He's a football player. This is American football. And his CBC shows like this. He has a little bit of mild thrombocytopenia, right? But his bone marrow, so as part of his initial evaluation, had a bone marrow for the first time. His cellularity was 40%, normal cytogenetics in fish. What do you do? So is this true or false? I hear this all the time, I do not need to send genetic testing because my patient looks well, right? And this is an interesting conundrum. It's sort of, I was intrigued by the discussions yesterday in the CCUS session. I think that you're dealing with the same thing. So there were a couple of things that struck us: neutropenia, thrombocytopenia, marrow cellularity, and so we actually sent sequencing, and he has Shwachman-Diamond syndrome. And so this, of course, impacts his ability to be managed. We now have an opportunity to try to monitor him so that he can get timely transplant if he ever needs it before he develops AML, which, as I've showed you, once they develop AML, it's really tough. But this is the other thing I hear, true or false. I don't need to worry about MDS surveillance because my patient looks well. And just in the interest of time, I'm just going to say that I can't tell you how many times I've gotten calls from patients or physicians where they have a patient with Shwachman-Diamond syndrome, and the first time they came to attention was their AML. And when they tell me why they didn't get surveillance, I mean, I don't want to make them feel bad or anything, so I don't bring it up, but they say, well, we didn't bother with surveillance because the neutropenia was very mild. Asymptomatic, right? Mild neutropenia, no infections, no problems. Why rock the boat? And so my point here is, because the prognosis is so dire, if you develop AML, and because there's something you can do about it, I think that surveillance for Shwachman-Diamond syndrome is very helpful. However, what is the goal of surveillance? We want to reduce morbidity and mortality, right? It's not nice to, in pediatrics, we have to put children under general anesthesia. This is not a nice thing to do every year, right? So you better make sure it's worth it. And we're not sure, so sometimes when I think about who should have surveillance, we think about what is the magnitude of the MDS AML risk? Is it a high risk? Is it a low risk? Maybe you don't need to do it for everybody who has a genetic predisposition, which I would argue we shouldn't do it for everybody. Are there markers available for impending leukemia? I mean, if you're going to do surveillance, you hopefully have something that will allow you to catch it. Is there a survival benefit to early intervention with transplant? If it doesn't make a difference, then why do surveillance? And you really have to look at the outcomes of MDS and AML in the particular disorder that you have. So I didn't know if anyone had any thoughts about this kind of screening.
Please.
I don't have thoughts about this type of screening, but I think, of course, the way a patient looks has virtually nothing to do with what's going on in the bone marrow, because it takes a long time for whatever's going on in the bone marrow. But I had a question, actually, that relates to the neutropenia. So we're told that the normal range for neutrophil, ANC, could be lower, for instance, in African Americans. And there are families, Asian families, other families, where the patients have a low neutrophil count. And traditionally, like if somebody's 50 years old and they have an ANC of 1,000, and their father, mother has a neutrophil count of 1,000, we don't do anything as adult physicians. We say, oh, it runs in the family. So I'm wondering if either of you have any insight into what do you do with borderline neutropenia, and what is the molecular or genetic basis?
So I'll start. So that's a terrific question. So I work in the non-malignant hematology clinic, so I see this all the time. And we don't do genetic testing on everybody with neutropenia, but we do use some of these clues that Jane mentioned. So if they have any red flags in terms of personal history, family history, anything else in the labs, do they have macrocytosis? Do they have 2 lineages down? And do you not have another explanation? So they're not one of the ethnic groups that you mentioned, et cetera. Then I just monitor them. I don't, or sometimes just even let them go and say, come back if something happens. But we
because they look well.
Well, no,
I'm kidding.
It's because their evaluation looked well. I'm gonna qualify that because it's not just that they looked healthy; it's because their whole evaluation looked healthy in terms of. But it does require, and you have to dig for that family history. And I'll give you a converse example. We had a patient present with monosomy 7. This was, and we did whole exome sequencing and found GATA2, and we got scooped on that one. So we didn't know what we were looking for at the time. But the mother, who actually was a nurse in our pediatric oncology clinic, told us, oh, I was diagnosed with mild leukopenia, decreased white blood cell count as a child, never had any problems. So, I don't think that I would have done anything differently for that mom when she was a child if she presented with an isolated mild leukopenia. But now with this family history of a child with something, we tested mom, and she also had the GATA2 mutation. So I think that, we don't want to go crazy with genetic testing, but I think that if you do a thorough evaluation and it looks healthy, the evaluation looks healthy, I do hold off. I don't know.
I'll take the converse to that because I think that with the decreased penetrance of some of these syndromes in adults, by referring them to get evaluated when you know there's a family history, clinically, if the whole family has lived decades, they kind of have told you their story a lot. But sometimes I've found that once I see those patients, I find a lot more than what was there, because it really does take some degree of experience with different syndromes. So we had a family that had neutropenia that my colleague said, you know, I don't think there's anything else going on here in the history. She had pneumonia a long time ago, that's it. And I looked at her feet, they were covered in warts, because as adult doctors, we don't take off the socks, you know, we never do, we don't have any need to. And she had actually had a mycobacterial infection. She just didn't know the name, and we had to get records to find that. So then when you expand it wider to the family, there are people at risk who actually really had symptoms already, and we could intervene there. So from a clinical perspective, I think getting a thorough evaluation is very helpful, but the family history story does sometimes help you because they've shown you what their trajectory is. And lastly, obviously for research purposes, those are amazing discovery families, and someday I think we're going to have a genetic hematology fellowship. I would love to take applicants if I could start that, because if you think about it, the iron disorders, hemoglobinopathies, white cell disorders, all these marrow failure, there's so much genetics that it's only going to get more complicated in our practices.
No,
I just want to say, I don't think there's any disagreement. I think that that would not be a healthy evaluation, and then I would pursue that further. But it is predicated on a thorough evaluation by an expert.
But is there any, if it's healthy, is there any understanding for why neutrophils are low in certain populations? Is it they're more adherent? Do they actually have?
There have been blood cell antigens that have, and genes associated with sort of, for example, decreased neutrophil counts in the African and certain populations. So the genetics can be helpful there as well, but we don't routinely send that.
Yeah, I'm very sorry. I think we have to stop because we are 10 minutes over time. I thank all the speakers and the discussants for this really lively session and close it. Thanks a lot.